All right. Thanks so much, Dave. For everyone on the presentation today, my name is Aaron Nusstein. I am the interface specialist over here at CliniSync. I guess just briefly, I've been here for probably 5.5 years, and 5 of those years I've been working in the CCDA space, and I know that there's a lot of interest and conversation over contribution and query of CCDA. So figured let's have a little conversation. I'll present all of my knowledge, and we can go right into it. So first off, I think just very simply, what is a CCD? CCD stands for the Continuity of Care Document, and there are several different subsets of CCDs, summarization of care, discharge summaries, et cetera, et cetera. For the purposes of this presentation, it's kind of all just bundled into that single format of CCD. And a CCD, quite simply, is just an XML structured document that was developed by HL7. The most up-to-date version right now is the CCDA 2.1, and the CCD right now contains medications, allergies, immunizations, problems, and a whole host of other data points that can be found in there. And that makes it a little bit more useful than just sending HL7 messages back and forth. It's a little bit more of a singular, robust piece of data that a clinic or a hospital can use to view all of that data in a singular space. And as I said, there's a ton more data elements available through USCDI v3. If you go to their website and go kind of into the data elements there, we could spend probably 30 minutes just going over data elements. So there's a lot of different things you can add to the CCD. If you talk to your EMR, you can kind of see what is available to you. With CCDs, there are also style sheets. So obviously XML is not the prettiest way to view data. Style sheets are kind of a way to take those XML formatted documents and turning it into a human readable. And each of your EMRs will be able to kind of customize, well, not so much customize, but they have their own style sheet that they use to present CCD data. And if you see data in there that perhaps you think is missing, or data that you don't want to see anymore, they could potentially go through and customize that style sheet for you. Within the CliniSync environment, there are 3 types of CCDs that you would be able to see from us. One is simply a stable CCD. That's just the raw data that is published from the hospital or the practice. You submit the data, and we are going to present it as it is. We're not changing any of that data. It is what it is. The on-demand CCD, which is a CCD that's generated by our tech vendor Health Catalyst, and that is normalized HL7 data that we have on a patient. It's in the format of a CDA R32, and I'll kind of go into that a little bit later. And then there's the comprehensive CCD, which we will also talk about later, but that is the main document that we'll provide back in queries. We can go into the next slide. And I kind of wanted to go just briefly over the difference between CCD terminology, because it's a lot, there's a lot of similarities in the terminology and everything like that. So when someone just is talking about a CCD, they are actually talking about the physical document that is generated. And then there's also CCDA, Consolidated Clinical Document Architecture, and this was essentially the rules set out by Meaningful Use in 2011 that essentially comprises the structure that the CCD should be generated as. I think over time, there's been several different structures and methodologies that have been presented over time, but right now CCDA is the main structure. And then there's CDA, which is sort of the original document structure out there for clinical summaries, set out in 1999. But due to a lot of the protocols and measures that have been set out by various organizations, you're not going to see CDA a whole lot. But we do create a CDA document for our on-demand, but I can kind of get into that a little bit later. Go to the next slide. Yeah, so to talk about the CliniSync Comprehensive CCD just for a second, which of course is another acronym that, CCD, but I digress. The CCDA is a version 2.1 generated document from CliniSync vendors. It comprises aggregated CCD data on a patient. It will contain all CCD data for a patient that we have available, as well as 365 days of HL7 data that we have on that patient as well. And we try to give you as much data as we possibly can in our comprehensive CCD. However, we do not include imaging, and we do not include PDFs. The data that you see in that comprehensive is both normalized and deduplicated, so you're not going to see, multiple data points, that have been submitted. If a hospital submits, a CCD a day on a patient and it contains the same data, it's not going to duplicate, 30 times or however many CCDs are published for that patient. And this CCD has been validated by the EHealth Exchange and is HL7 compliant. So everything that you see in there is set to a standard and is, validated by all of the organizations that deal with this type of data. And comprehensive right now is available through Query and Retrieve. It is also available through EHealth Exchange and Care Quality, which we are currently integrated with. And a comprehensive will also be generated through the Community Health Records Find External Data feature, or Find External Documents feature in the Documents tab. If you do query a patient and there is no CCD data, then we will generate that on-demand document for you, which I said is just HL7 data, and it's in that CDAR32 format. However, you will not get that CCD back when you query us through eHealth Exchange or Care Quality, because that document is not vetted and is not compliant with some of those regulations. So, and if you are a client that is currently receiving documents from us through Query and Retrieve and are getting back the comprehensive CCD, we're currently doing sort of the beginning stages of review of the comprehensive. It's been out for probably 6 years now at this point, and we're kind of looking at ways we can improve the comprehensive CCD. So anyone that is currently receiving that document, if there are any sort of feedback that you guys have, feel free to reach out to us, and we can certainly look into making that a feature here in the near future. Yeah, so PNR and QR, provide and register, and query and retrieve. These are the two interfaces that we use for CCDA exchange with the HIE. Provide and register has one protocol, which is the outbound push, and query and retrieve is to query documents from CliniSync, and there are two different protocols on that, and I will get into that a little bit here in the presentation. These are methods of CCD exchange developed by IHE International, and their initiative was to create a coordinated use of standards to exchange CCDs, which has been really helpful, I think, in the community to, you know, like I said, set a standard and make integration with other organizations, hospitals, practices, HIEs a lot easier. These interfaces are they're generated by a requester, and you are sending that request to a responder, and that creates a point-to-point connection. Yeah. These interfaces mainly utilize web services. So essentially, you are going to we set up a URL endpoint for you guys to communicate with. And whenever you want to query or publish a document to us, you would use that URL. The security behind those connections is based in certificates. So what we would do is we engage in mutual authentication. So essentially what we would do is exchange certificates. There's a public key and a private key. We would give you our public key. You would give us the public key with your organization. We would install that on the necessary in the necessary places in the servers, and assuming everything looks good there, communication would be established there. And with identity identifiers to determine, you know, who is the publishing entity and who is querying us. And this is, for us at least, the biggest piece of setting up an interface with PNR and QR. Determining what those OIDs are is pretty critical. Without them, we would not know, you know, who is, you know, where to put a document, where to send a query. So getting those correct upon implementation is important for us. And with these two, automatic triggers can be set up on the EMR side to send those queries out or to send those documents out. And we can get into that a little bit later when I go into further detail on PNR and QR. But you can also do so manually. And I would talk to your EMR to see which one that they engage in. So yeah, going into provide and register, this is just a way to submit a CCD via a push request. With our current architecture, we could have you send directly to our technology vendor, Health Catalyst, or we currently have a Cloverleaf engine on the CliniSync side that you might also send documents to, and we would essentially be a pass-through to Health Catalyst. The Health Catalyst manages the repositories and the registries, and we just kind of act as a little bit of an intermediary to kind of, you know, create a little bit of a buffer there in case there are downtimes and anything like that. Provide and register uses XDSB protocols, sending ITI 41 transactions. It sounds a little bit of jargon, but essentially, if you want to request setting up an interface like this, that's sort of the lingo that your EMR will want to hear to know, okay, this is the type of interface that we are going to be setting up. And XDSB just simply means cross-enterprise document sharing. Yeah. Typically on the EMR or the practice side, one of these publishing requests would be sent on the close of an encounter, which obviously that's what you would want to, that's when you would want to send a document to us once the patient has been treated and has been seen and has new data to be presented. The important OIDs for provide and register. There's the assigning authority OID, and this is going to be associated with your patient ID. These two are essentially going to create a link so we know, okay, this identifier is matched up with this organization, and that's the assigning authority of that document. And there's also the custodian author OID, and that determines the actual source of the document. So there's an OID that determines the MRN number or the MRN, and then there's an OID that determines the actual CCD. CliniSync is able to register patients using the data that's within the CCD. So you do not require an ADT feed to be able to set up a CCDA interface with us, especially a push interface. And those published CCDs will be available in the CHR via the Documents tab, and also available through Query and Retrieve, obviously. I will note that with the CHR, the data within the CCD does not get permeated throughout the other tabs of the CHR for that patient. Any CCDA data will just live in that Documents tab, and you can view the documents and its data through that means. And if there are any issues with that XML structure, we're going to reject the transaction. And obviously when we go through testing and everything like that, we'll, kind of push through all the nitty-gritty details of validating the XML and just making sure that when you do finally get to the point of sending CCDs, that everything looks good and Health Catalyst is happy and everything like that. However, if OIDs are not correct, there are no errors or anything like that occur. So if you do start publishing CCDs and those OIDs are not correct, it can have ramifications downstream. So, for instance, CCDs might not be available in queries or might not be seen in CHR. They might create new patients upon every published document, et cetera, et cetera. So when we do go through testing, just making sure that those OIDs are correct is a very big piece of this. And not only that, but in the future, if OIDs do change while you are live, we will want to know that so we know to update our side before that change occurs. And then just one quick detail on the data that we accept. We do not accept substance abuse data, CFR 42. So as per US CDI, so if there are data elements that do contain substance abuse data, whether that's medications or diagnoses or whatever the case may be, we would like that data filtered out if at all possible. Going along to query and retrieve, and as I mentioned earlier, there are two different protocols in query and retrieve. XDSB is the first one, and this XDSB protocol uses two different types of transactions: the ITI 18, which is the query, the document query, and then there's the 43, which is the it's got that backwards a little bit. There's the 18, which is the patient query, and then there's I'm sorry, I got it right the first time. The 18 is the document query, and the 43 is the document retrieve. So these are typically sent upon an admit or prior to a visit, such as a scheduled visit to be set up prior to that visit. And the only OID that is required for build here is that assigning authority ID that matches up with that patient ID number. And essentially the workflow for this interface is you will send us a query request, that ITI 18, essentially saying, hey, we have a patient with this ID. Do you have that patient available, and is there any documents? And we will either say, yes, we have that patient available, and here is the available documents list, or we will say that that patient either does not exist or that patient does not have any available data to be queried back. And once we respond with a success or that there are documents available, you'll send out that 43, which essentially has that document list that we provided back to you, saying, hey, we want documents with these document IDs, and we will provide that back to you. And yeah, that patient matching, like I said, is related to the assigning authority and the MRN. Because there is an MRN associated with this, that patient needs to be registered prior to the query. So an ADT feed is necessary to be able to move forward with this. And it's one of our most common errors related to QNR, is that there's some sort of either an ADT wasn't sent, therefore no match could be made, or the query and the ADT that were sent for that patient were sent at the exact same time, and the query got to us first. So if the query gets to us before the registration event occurs, then unfortunately that's we don't know what to match that to, so we'll error that out. So like I said before, with XDSB and this type of query, OIDs are very important, so we need to make sure that those are all lined up. And protocol bridging, I wanted to just briefly touch on that. Essentially, it just upconverts your XDSB transactions to XCA, and that allows you to return our comprehensive document through XDSB. That also allows us to apply an ignore list, which is essentially just if there are organizations you already received data from, we can and there's data available within CliniSync, we can block that out using OIDs and make sure that you are only returning data that you want to return in your queries to us. And then the other protocol, like I mentioned earlier, is called XCA. This is essentially it's very similar to XDSB. However, it does not utilize MRN numbers to find a match within the HIE. It uses demographics. So essentially, you will send us what is called an ITI 55 cross-gateway patient discovery. Essentially, you will send us a list of demographics: first name, last name, date of birth, administrative gender, and street address. We will use those criteria to provide a list of patient IDs that we have available, and essentially once you create that linkage, your EMR should be able to cache that ID, and for future queries you would only need to go through the 38 and the 39 because you already know that that patient exists on the at the HIE, and then the 38 is your document query, and your 39 is your document retrieve, which occurs very similarly to the XDSB. Again, these are sent prior to an admit. It utilizes a different type of OID, which is called a home community OID. It's essentially it's a very similar ID to the MRN, except it recognizes the source of the query without utilizing that MRN number. So, and that is present within all three transactions of XCA. Again, because we use demographics to match on an ITI 55, we don't require that registration for matching. So an ADT feed is not necessary to move forward, and no protocol bridging is needed here because this is we're able to provide the comprehensive document just through XCA. And just one point of note, if you are going to engage in XCA integration, we do require a SAML token, which is really just another method of security to make sure that we know who the querying entity is. It's more of a technical thing. If your EMR asks whether or not CliniSync requires SAML, just for XCA, that is the answer to that is yes. And then moving along here to, I think the title of that is wrong, but we're talking about EHealth Exchange and Care Quality. So CliniSync is currently up and live with Care Quality and EHealth Exchange. We act as both an initiator and a responder, and we connect to the Care Quality through the EHealth Exchange hub. And like I said earlier, it only utilizes XCA. So if you're an XTSB client, we do offer the ability, because of protocol bridging, to be able to query EHealth Exchange and Care Quality, thanks to that that functionality on our side. And I kind of can get into that a little bit later. I think I have this in the notes here. So CliniSync can be queried from both networks. If you are if your hospital or practice does have a connection to Care Quality or EHealth Exchange, you can reach out to us through those means. You would just need to import the CliniSync endpoint from the provider directory into your own, and you can be able to reach out to us through those means. We can also query EHX and Care Quality, and we can even have routed queries through your organization to be able to pull back those documents within those networks. Like I said, with XDSB clients, we can upconvert your XCA, or we can upconvert it to XCA, so we can reach out to those organizations and provide you back a document from whoever is available on those networks, whether that's the VA, DoD. There's hundreds and hundreds of different organizations that are available through those networks. So yeah, if you're interested in that, we can if there are organizations that you wish to reach out to, feel free to let us know, and we can start an integration with that. Just to note that you would receive multiple documents back. You would receive that comprehensive document from CliniSync, as well as any additional documents that would be available on those networks. And I think that's all I have for you today. So if there are any questions, feel free to, Dave, if there are anything, please let me know.
Thanks, Aaron. Yeah, so we have just about a minute left in our standard meeting here, but if there are any questions in the group, feel free to supply those to the chat, and we can answer them quickly here if there's anything that anyone would like to ask. All right, so Aaron, it looks like we have one question here. So let's see, what is CliniSync's roadmap for becoming DAV certified?
That's an excellent question. I think we would have to go back and talk to some of our internal resources. I'm not sure that we have a current roadmap for this, as we're still kind of getting integrated with both EHealth Exchange and Care Quality, and making sure that those connections are rock solid. So I don't think we have an answer for that at this time.
Okay. Another question here. So since this is a centralized storage of patient data, does the opt-out law apply in the situation here?
It does. So typically with consent, what we would ask, at least on the practice side, is that if there is an opted out patient and is seen at the practice, that the document not be sent to us. That way, it kind of mitigates that consent rule on our side. And if that patient is opted out on the CliniSync side of things, if you do query us, that will return a similar error to a no patient found. We would just return back that the patient is either not available or that patient is opted out. So CCDAs do follow the same sort of rules. It's just a matter of managing that consent model, both at the practice level and within the HIE.
Awesome. All right. So those were the only two questions that we had so far. if there's any other questions that anyone has, I think we have time for just one more. If not, there is contact information on the slide deck there. The information email will direct you to our just general triage line of folks kind of handling that internally. So we will be able to get your question to the appropriate person, and or you can give us a call, of course. Last but not least, I did want to mention that this webinar was recorded, and we will be sending that out to the contact list for this meeting, in addition to the slide deck that Aaron was using as a visual guide as well. So that, as well as the a link to the webinar on our YouTube page, will be sent out later on. So thank you all for joining us today, and we look forward to chatting with you in the future. Thank you, Aaron.